All right, 10:55, so we'll get started. Just a couple housekeeping things before we get started. If you have a question, just please raise your hand and I'll bring a microphone to you so then our friends that are watching virtually can hear too. If you have any questions and you're on virtual, please just use the app and we'll direct your questions then. Another friendly reminder, please fill out the survey session so you know how the session went. And then if you're doing the continuing education credits, it's the same link to fill that out. So, all right, I'll let our panel take it away.
Great, thank you. Hi, I'm Melanie Botel, and I'm the Director of the Division of Behavioral Health. We're part of the Department of Social Services. I think, should we just start doing quick introductions and then we can dive into the slides?
Sure.
Okay.
Good morning. I'm Janet Kiddems. I'm the CEO of the Helpline Center.
Good morning. I'm Kim Hansen. I'm a director at Southeastern Behavioral Health Care.
And I'm Christy Seidel. I'm the Director of Behavioral Health Services at Aval eCare.
Maddie Miller, Crisis Program Director at Lewis and Clark Behavioral Health Services.
Great, and I'm really happy to be here today with you all to talk about what things are looking like currently for crisis care, behavioral health crisis care in South Dakota, some of the things that are currently in place and some of the things that we are working towards. And so one of the things that I just wanted to just share a little bit about is that we created a crisis. So yeah, this is one, we love our acronyms, and I wasn't able to really come up with a good acronym for this one because this has no vowels in it. And so it's a little bit tough for me to even come up with how to say it. But Behavioral Health Crisis Response Stakeholder Coalition. And so this was created a couple of years ago as we were looking at 988, planning for 988 to implement last year and how to just bring a whole array of stakeholders together to talk about what things should look like in South Dakota. And so you can see information on here. We've been meeting for 2 years now, looking at a wide array of how we should support implementation. We have a wide range of members on the coalition, including a number of, actually, I think all of you are probably part of the coalition in terms of the delivery of services. We have individuals with lived experiences on the coalition, just a wide array of folks to be able to provide information to us and have a voice in planning what behavioral health crisis services should look like in South Dakota. I do have a video. It's a short video that I was going to play, but I think I'm going to skip over that because this is a short panel and I want to make sure that we have enough time to talk. But if we have time still at the end, we can play this video, and I'm happy to share the link so that folks could watch that if you're really interested. It just really kind of walks through what it's like to experience a crisis if we don't have services in place, and what services, what it would look like then if we do have services in place. So it's just kind of a nice visual. And again, if we have time, I'll come back to that. The main thing that I wanted to talk about, and what we have all of our speakers here today talking about, is really looking at a 3-pillared crisis now model. That's the model that we're implementing in South Dakota. And it's based on, again, 3 pillars. And so the first one is someone to talk to or someone to call. So that first, if you're feeling that you're in a crisis, that you have somewhere to call, being able to talk to somebody 24/7, 365 days out of the year. And that's where 988 comes in the Helpline Center. Then we also have someone to respond. And so sometimes you also need somebody to come out and talk with you, or to be able to have somebody kind of face-to-face with you. And so that's where we have mobile crisis response, including virtual crisis care with Aval and in person. And it will have Kim Hansen here talk about that and what Southeastern Behavioral Health Care provides as a mobile crisis team. And then we also have that we do need somewhere to go sometimes. And that is where we have appropriate regional facilities. So I think we all probably are familiar with the Human Services Center down in Yankton, our psychiatric hospital, which is tucked away in our southeastern corner of the state. And so that's not very easily accessible if somebody's having a crisis in other parts of the state. And so we're looking at having more localized responses where people are able to go more regionally and be closer to home when they do need somewhere to go when they're in a crisis. And you might not need to be in a hospital setting, but we do need somewhere to go. And so Maddie is here to be able to talk about what's happening at Lewis and Clark Behavioral Health Services in Yankton. And just a little bit more about that, and I wasn't going to take a whole lot of time to talk about this, but I think one of the things that's really exciting for us in South Dakota is the support that we have at the state level, at the legislative level for supporting behavioral health crisis in South Dakota. And so this goes back to 2021 with Governor Noem supporting our behavioral health service delivery transformation. And that provided $15 million from Federal American Rescue Plan Act dollars for us, one-time funding to be able to help support the building construction of facilities regionally. And so that's where Lewis and Clark again comes in. We have similar projects happening in Rapid City, in Watertown, in Yankton, looking at additional opportunities that we'll have in the state. We still recognize that's not covering the entire state, but we have more operations coming into place. We also were able to, just this past legislative session, be able to get get an appropriation for supporting the operational costs for 988 happening permanently, as well as the ongoing service delivery that happens at our appropriate regional facilities. And that's something that's really exciting and something I think that needs to be celebrated for us, that, you know, we have at the state level just recognize that this is something that's really important, and that we're really providing that investment into our citizens of South Dakota. I think that turns it over to you now, Janet.
All right, thanks, Melanie. Oh, yeah, that would be helpful. So just to level set, I'm just going to give you kind of where we're at with 988. Just to refresh everybody, 988 was launched last July 16th across the nation, and of course here in South Dakota. The Helpline Center is the only crisis center in the state, and so we answer calls from all over South Dakota. And once again, you can call, text, or chat with 988. So in South Dakota, it's a partnership with the Department of Social Services, as Melanie talked about, received funding through the legislature to sustain and support 988 into the future, which is a blessing for the state of South Dakota. Not all states are in that position where 988 has been funded, so we are very thankful for that. And just another point that I always like to make is that we continue to respond to people and provide the care that they need, and 95% of the time that we are able to de-escalate those callers, and they don't need further intervention. And so we're very, very pleased with that. I'll pop on to just talk a little bit more about that with this diagram. This seems to resonate with people very well, talking about the interconnection between these three-digit phone numbers, 988, 211, and 911. Clearly, everybody recognizes 911 because we've known about that for decades. And so that's the phone number. Obviously, you call in an emergency situation for fire, police, ambulance. And then 211 has been around for a couple of decades, and the Helpline Center has been answering that. And just to clear up any confusion, 211 is still here in South Dakota, did not go anywhere with the introduction of 988. 211 has always been for what we call information and referral. For those community resources, we answer a lot of questions about housing, about food, about financial assistance, and a plethora of other kinds of questions that come on 211 that are listed up there in the diagram. And then 988, of course, we are talking mostly about that today, and that's for any type of emotional distress, suicide, a substance use kind of issue, and mental health related questions that come up. And so in the diagram, you can see that those three numbers intersect with each other. And this is the part that I think is so revolutionary about 988. We have formed a partnership with the 911 call centers across the state. So when they have a call that comes into 911 that is a behavioral health issue, and that person is not in imminent danger, they're able to transfer that call to the 988 staff. And as we've built the relationships with the 911 call centers across the state, every day we have calls that are transferred to us. And it's providing a better service for those individuals who are experiencing some type of behavioral health issue in their lives, because the 911 operators are amazing people, but they're not trained in behavioral health. And so they're thankful that we're available to get that call transferred to us. We certainly handle that, de-escalate the caller, stabilize them, develop a safety plan with them. And very rarely do we have to transfer it back to have like a dispatch of law enforcement in those cases. And then likewise in our office, since we answer both 211 and 988, Our 211 staff is a separate team than our 988 staff. Our 988 staff are master's prepared individuals who generally have social work degrees or counseling degrees. 211 staff are bachelor level individuals who focus really on knowing the resources in South Dakota. So our 211 staff, when a behavioral health call comes in, they transfer that to the 988 staff, and the 988 staff are just better equipped to handle those types of phone calls. So all working in partnership with, each other. And then I just want to share a little bit about data. And I apologize, my slide, when I submitted these, we didn't have our April data up, but on our website, we have a data dashboard that you can look at any point in time. And so I'm just super excited that 988 has really done well in South Dakota. We've done a nice job of building awareness, encouraging people to reach out through the phone, texting, or chat. So actually the call volume is up over 6,000 through the month of April. And it continues to grow. Every month we do our monthly report, and it's a steady increase every month, hasn't gone down yet. And we anticipate that that will continue to happen. Most of our contacts are through the phone, about 20% are through text or chat. Generally speaking, our text and chat folks are a little bit younger. They tend to be adolescents or in their 20s. Not to say that adults don't use the text or the chat feature, but it's just generally our younger audience that uses that method. We do track demographics for callers. Oftentimes, we're not able to get all of the demographic information because it's just not appropriate to ask in a crisis situation. But oftentimes, we call those callers back. We do follow-up support with them, and then we're able to get more demographic information for them after they're in a stabilized kind of position. But we see kind of a split between males and females with our demographic. I thought it would really trend a lot heavier towards female, but it's a little bit heavier towards female, but it's pretty balanced between males and females. So hearing from all kinds of folks all over the state, and we certainly have a small percentage of our callers that are from our transgender population also. So that kind of gives you a sense of where we're at. I should talk about the presenting concerns. We hear a lot, obviously, about suicide, so that is our #1 presenting concern, but we also hear about relationship, family conflicts, depression, anxiety, substance use are kind of the top needs when people are calling in. So not a surprise with that. Those are all types of issues we thought we would hear about across the state. So looking forward to continuing to grow 988 and build the awareness and encouraging more people to take advantage of the service. And with that, I'm going to pass it over. Oh, one last slide. If you need, I know materials, you've been by our table, but if you happen to need more resources, promoting 988, we have those available, and you can always go on our website and order those at no charge. We send them out all over the state for people. So thank you very much.
For time saving, I am going to skip a couple of my slides here. So we will start with, back now. Okay, so the mobile crisis team was implemented in 2011. There was years of collaboration that happened with community stakeholders to produce a solution to the increase in mental illness holds that were happening in our community. At that time, there was no option other than to send somebody to the hospital if they were meeting criteria to be placed on a hold. The mobile crisis team is managed by Southeastern Behavioral Health Care, and it's reimbursed by Minnehaha County. Mobile crisis is a partnership with law enforcement to reduce the number of unnecessary mental illness holds. And I want to kind of go back to that word unnecessary. I don't ever want to give the impression that there's not a time or place where somebody might need to go to the hospital. And so that's why we really need to listen and develop a safety plan when we are meeting with those individuals and considering leaving them at home when they've been in crisis. So a mobile crisis is a way for an individual experiencing a mental health crisis to talk about their situation and be heard. We're a 24/7, 365 program. Mobile Crisis provides services to both Minnehaha and Lincoln counties, and any of the law enforcement agencies in those two counties may call us out if they encounter a person who is meeting criteria for a hold. Mobile Crisis is law enforcement activated. The team is comprised of 12 mental health professionals who are skilled in crisis de-escalation. So as far as law enforcement and their role goes, when they encounter a situation where a person is experiencing a mental health crisis and they do meet the criteria to be placed on a mental illness hold, so that would be that the individual is a danger to themselves or suicidal, they're a danger to others, homicidal, or they are mentally ill to the point of being unable to care for their own basic needs. If, their electricity has been turned off, they can't move around their apartment, they don't have any food, that would be inability to care for self. So then at that point, we would look at taking them in on a hold. And if law enforcement encounters an individual who is experiencing one of those issues and they think that the issue could possibly be de-escalated, they would page the mobile crisis team. Now, there are some reasons that we may decline a call. If an individual that we are called out on is too impaired by drugs and alcohol to the point that they're unable to communicate with us, we would look at sending them to the link or another community source versus trying to de-escalate them when they're in that state. If the person is a minor and there is not a legal guardian present, we cannot talk to that child. We need to have a guardian there to sign off on consent in order for us to meet with them. If an attempt has already been made, such as somebody has ingested pills or injured themselves, they need medical help before mobile crisis can meet with them. And if the person is requesting to go to the hospital on their own, if they say, I'm having a bad day and I feel like I want to go to the hospital and get assessed, we would just recommend then that they go to the hospital and do that. And if there is no probable cause, periodically we will get a call from law enforcement and they'll say, I'm with this individual who's having a bad day and they just really need someone to talk to. If there is the potential of putting someone on a mental illness hold and we're taking away their civil liberties in that state, then we do need to have probable cause. I'm going to go ahead and skip this slide. So once the mobile crisis team is on scene, we meet face-to-face with that individual and we meet them where they're at. So if they're at work and there's a private place to meet with them, if they're at home, if they're outside in the community, we will go wherever they're comfortable meeting with us. And then once we're face-to-face, we just ask them, tell me what's going on today. Why have things gotten to this point in your life? And just really giving them that opportunity to talk and be heard and kind of process through that situation. And then our goal is to complete a safety plan and leave that individual at home so that they can remain with their family, their pets, go to work the next day. And as I said, there are times where that is not able to happen. And then this is just really a great opportunity for the individual to work through that issue and process through things. As far as the safety plan is concerned, it includes questions about why law enforcement was called, and then general safety questions, including a promise from that individual not to harm themselves or others. And then we visit with them about getting referrals to community resources so that they're not continuing to be in crisis, so that they can work through that issue. And then it also talks about things that they have to look forward to in their life. So there's 3 different sections on the form, and the last question on the top section is, tell me what you have to live for. Why would you not hurt yourself? And so if they say something like, well, my family, I'm very religious and I don't believe in suicide, they're probably going to be okay. And if they hesitate or don't have a reason that they feel they want to be here, then we would again need to relook at the possibility of them going to the hospital. They do agree to remove means of suicide if they have a plan and there is an item. We do not remove firearms. We either rely on law enforcement to remove the firearm or family or a friend to get that firearm and secure it. And then we do a plan for their next 24 hours. So if we ask them what their plan is for the next day, and they say that they're going to take a shower, eat, go to bed, go to work the next day, again, they're probably going to be okay. If they don't have a plan such as that, then again, we may need to reassess whether they need to be hospitalized. And then both the individual and the mobile crisis staff member sign the form, and the individual does get a copy of that plan. Now, if the safety plan doesn't work, we would first talk to that individual about, are you willing to go to the hospital and get assessed on a voluntary basis? If they say yes, law enforcement does transport them, we follow behind, and then we meet with the assessment team and discuss what the situation is and why that individual is there. Now, if that doesn't happen, then law enforcement does proceed with the hold. Law enforcement is the only entity that can initiate a hold and take a person into custody at one time. And so we do rely on them to do that. We try to be very honest with individuals we're meeting with. If we're not comfortable leaving at home, we just tell them, hey, I'm not comfortable leaving you home, and this is why. So honesty is always the best policy when that situation does occur. And then as far as follow-up is concerned, once somebody has been a mobile crisis call, the next day we give them a call and just check in and, hey, it's Kim from Mobile Crisis. I wanted to check in and see how you're doing today. Most of the time they are feeling better. And then at that point too, we would revisit the option of, are there any community resources that I can help you with so that you're not continuing to be in this crisis, or are you willing to work with a therapist so that you can work through some of this? And so we do help with different referrals so that they can move past their crisis. And then two, of course, we encourage self-care, and we give reminders to be safe and to call for help if needed. And with that, I am going to pass this on. I have a couple more slides, but for time, I am going to skip them. Thank you.
Thank you. I'm glad we followed each other because I feel like we're doing exactly the same thing. I'm just on a tablet and not in her counties. So Avell E-Care Crisis Care, VCC or Crisis Care is what you probably hear in the community in South Dakota. So why we're here today, you guys know this. Mental health crisis is all over. You know, the study here, we want to be partners with law enforcement with our crisis care service. We want to be part of their team and an asset to them so that they have the tools within their community, whether they're in rural South Dakota, West River, they're up north, we're available to them. So as you know, there's a huge increase in crisis care calls for law enforcement. It says 20% up to 84% say mental health related calls have increased during their careers. So with our virtual crisis care model, very similar to Kim, our law enforcement, we're in 40 counties across South Dakota. We started in 2019, and it's not the physical body. We have the tablets or iPads with law enforcement. So everyone's equipped with a tablet or an iPad, and it has the application on there. So they will call with Endora Hub here in Sioux Falls, South Dakota. We have a team of 19 psychiatric trained nurses who have over 220 years of experience. We have psychiatrists and social workers on staff. We operate 24/7, 365. They call us, they say they have a mental health crisis, and this individual is willing to talk on the iPad with us. So we will remote into that iPad, whichever one that they have, and we'll do a similar safety assessment with that individual. We'll really develop that rapport as fast as we can. When you're not in person, it's really hard to get someone to trust you really quickly on an iPad. COVID, one of the benefits of it was telehealth, and now they trust us a little bit more talking over a camera. So developing that rapport, getting that safety plan, means restriction, what's going on in your life, trying to de-escalate as fast as we can. One of the benefits of our program being virtual, we're not going to see them in Walmart. We're not going to see them at a school event most likely because we're not in their communities. We're not in their counties. And so we feel like they open up a little bit more to us with our program. We've started to expand outside the state of South Dakota. We are in 13 of the 17 counties in Nevada. And also we just started a program up at SDSU. That's our first collegiate school that we're involved with. So working with PD on campus to do crisis care. The benefit or the goals that we've had is that 80% of those individuals in that immediate crisis, we've been able to de-escalate, develop a safety plan, and allow them to remain in place. After we do our assessment, we fax our assessment or scan it however the officer wants it to them. And then we do send a referral on to their community mental health resource in that county. We work with law enforcement on who that is, and they'll get a secure email and we'll have access to the assessment. So then they do the call 24 to 48 hours post our crisis assessment. This is just a quick example in Butte County. As always, we will ask the officer to remain in line of sight just for safety of that individual, to make sure that they are secure, but also to give them the privacy to open up to us on camera. Once we're done with the tablet and do our assessment, we will hang up from the video and we will call that sheriff back and just say, this is what we talked about. This is the plan we developed. Are they okay to remain in place, or do they need that involuntary hold? Or, hey, they're ready to go in for an inpatient stay and they're voluntary. So really work through that with that officer on scene and just be a collaborative partner. The final say, of course, is that law enforcement's say, is because they are on site. We are not. So it's always their final say on what happens.
All right, so I'm going to talk a little bit about the appropriate regional facility model, and to just give you a little bit of background, Lewis and Clark became an appropriate regional facility back in 2021, but really our development of crisis care services has been happening for many years. We've had a crisis phone line 24/7 that anyone can call, where we can help try to provide resources, give them direction. But really our crisis beds that we opened were in response to the tornado that hit the Avera Behavioral Health Hospital. So just like communities across South Dakota, we do what we have to do to take care of people, and that was the solution that Lewis and Clark came up with at the time. Of course, we all know you build it and they come, and so we've seen a growing need for crisis beds. So we have been working on a couple of things. So we're currently in the design phase and implementation phase of adding 5 short-term crisis beds to an existing building that we're in. But additionally, we also broke ground yesterday on a brand new facility that will really bring a lot of Lewis and Clark services under one roof, and will also allow for 14 crisis care beds in the southeast region of South Dakota. So we have decided to name our appropriate regional facility services the CORE Center for Crisis Outreach, Response, and Engagement. And that's because while we do have a physical building with beds, we also do a lot of things similar to what we've been talking about today that are outside the walls of a building. We do operate a 24/7 emergency line, like I said. We have services for youth and adults. We have outreach workers that we're currently working to implement in some of the more rural counties that we serve. And we're doing that in collaboration with the VEL, with 988, and with the state, because we know that in the rural parts of South Dakota, we have to be creative in how we reach people and how we connect with them and give them care when they can't make it to our building. Our team within the CORE Center consists of behavioral health techs, crisis counselors, licensed nurses, myself, QMHPs, those rural outreach coordinators, and then we're also working to implement a security team. So just a quick snapshot for you of what Lewis and Clark does. It's quite similar to other community mental health centers in our state, like Southeastern. We serve folks with serious mental illness, with addiction issues, both at inpatient, outpatient, and then community treatment levels. So in terms of the new building that we will be starting construction on this summer, this will just give you an idea of what we've developed for design and how we're really creating what crisis care could look like for this part of our state. So we're going to have a 24/7 entrance where any individual or law enforcement could come, and they will be brought into the facility. We have rooms right away upon entrance for law enforcement to store their weapons, to kind of separate from that individual if they can, and we have dedicated rooms to do that first triage and intake process. We will have availability for children, and that's something that we know is a growing need. These rooms will be set up to hold kids hopefully for 24 hours or less while we figure out the next place for them to go, whether it's getting them back home or onto a hospital stay if that's something that they need. Adults will be able to stay a little bit longer period of time, up to 3 to 5 or 7 days, depending on the need. This is what our lounge area will look like for patients that are admitted to the crisis care center. And this is an example of a patient room. So of course, everything is going to be ligature safe. It really is a state-of-the-art facility and a design that was worked on for many years. And I can't even start to list all the stakeholders that were involved in getting to groundbreaking yesterday because I would leave someone out. But it was just really an incredible collaboration of many individuals and resources to make this new build happen. We'll have an observation style room for a little bit shorter length of stay for adults. So if we have individuals that just need a safe place to sleep for the night, if they're highly intoxicated, this would be the room that they might stay in. This is an example of what our nurses station will look like. The way that we have designed our facility is creative in not only how we have patient rooms placed, but also how we place our staff. We know that staffing is an issue everywhere, and so our nurses station is actually a hub in between our crisis care center and our chemical dependency treatment unit. You can see one unit across to the next, but that allows us to share that group of nursing staff, which is really critical. As we all know, nurses are hard to come by. Is that my last slide? Okay, thank you so much.
Any questions? In person or virtual?
You hit on it just a little bit at the end, but yeah, we're hearing about workforce shortage all over the place, and now you're like adding new beds and building new things. How do you plan to find help when there's seems to be not help available?
Well, for myself, I'm currently purchasing mailing lists for all of the licensed professionals and trying to create really creative letters to entice people to come work for us. A lot of it, I'm new to Yankton, so I joined Lewis and Clark in February. Some of it's relying on the folks that have been in that community for many years, and sometimes it's just who do you know that might be looking or who's available, relying on those relationships. We've done a lot of outreach with the colleges in the area, not just in South Dakota, but for us in Nebraska and Iowa, trying to find students that would be interested in engaging with us. And I think when we look at workforce, there's a lot of different ways to look at it. But I think one thing that we're also working on is not just our short game, but our long game. How do we create nursing internships and social work internships and programs that will invite students to join us even before they're done with school and working on getting our workforce built up before they're even graduated. So we always have openings. And I will say, though, that becoming a part of this team at Lewis and Clark, just like any of our communities and our mental health centers, we just work together to try to take care of people the best that we can, but it's definitely a challenge and trying to figure it out.
If it's okay for me to jump in as well, Phyllis, I think that's a great question. It is the reality for certain. I think one of the things that we have experienced with some of the other regional facilities is they have been delayed in their opening, partly because of construction. And so workforce challenges with the construction crew, as well as hiring the staff that'll be operating the facilities. We recognize that at the state level, at the Division of Behavioral Health level, and we have currently underway a project where we're working on workforce development. We have a contracted vendor who has been really doing a landscape analysis for us to look at what are other states doing around this, to be able to take a look at some options that we could bring in to South Dakota so we don't have to reinvent the entire wheel. We're also taking a look at, well, actually they have been doing, and I think some of you probably have participated in that, they have done a number of stakeholder interviews from the state contracted providers to other providers that are out there that aren't part of the service array that we support, to post-secondary institutions, so the folks that are teaching students coming up, what's attracting them into the field, how can we retain them, what are the things that are looking, that we can look at to recruit staff. We're building partnerships with the post-secondary institutions to be building, kind of as you talked, Maddie, about, you know, work experiences, internships, different kinds of things. We're taking a look at how we can, at our level, be able to support the agencies in hiring, you know, either recruiting or retaining staff. So there's a lot of work going on around that, and I think a lot of work to be coming still in that area, because certainly that becomes a challenge.
Any other questions?
Is any work being done on the state level to be able to have our interns be able to bill Medicaid, Medicare? Because I'm seeing a lot of our interns unable to work in facilities because they can't bill. I'm not sure if any of you have worked with that experience, but that's been a struggle for our interns in getting positions.
Yes, I'll start. I'm not the right answer probably for you, but you know, our South Dakota Medicaid is part of the Department of Social Services as well, where we're at, and I know that, you know, that's certainly some things that we do take a look at of who is able to bill and what are the credentials and the training and the supervision needed for that, and then taking a look at what we can do in terms of working with CMS at the federal level as well for that. But I think that's something I appreciate hearing that so that we can take back. And then I think it's finding a way to, yeah, how are my words are failing me. So what I'm coming up is like unbillable folks, which does not sound at all appropriate. But, you know, the folks who are able to deliver some services and supports that may be able to be done in a way that might not be able to be reimbursed, but still are able to kind of enhance all the service delivery that's happening as well. But yeah, I appreciate the point, and I'll take that back to our Medicaid team.
Hi, Melanie. So actually, a quick question. You, as a state, can approach your state Medicaid agency or authority to determine whether intern students working underneath the license of a licensed clinician can bill or not. So that's a state decision for Medicaid. Other states in our region do. Medicare students can bill for Medicare, even outside of a hospital setting. And that's a federal flexibility. Question for the panel. I was wondering if you all could talk a little bit about the role that peers and community health workers and individuals and families with living experience play in the crisis response system.
As far as crisis response goes, we do not currently have a peer support on our mobile crisis team. However, we have hired a peer support specialist within our agency, and that individual offers support to individuals who are receiving case management and also to individuals who are part of the specialty courts. That individual attends drug and DUI court as well as mental health court and offers support to the individuals who are participating, who are perhaps having different struggles to help relate with them and navigate their situations.
For Lewis and Clark, I would say that's something that we're probably working on that we haven't really rolled into crisis care yet. We do have a mental health peer support staff that started recently in one of our other departments. We also are working on implementing a drug and alcohol peer support within our drug and alcohol program. But I think even though we have many departments within our system, we all rely on each other because we know that our clients need to have varying levels of services and support. So I think that's something that will probably evolve over time as we continue to grow our crisis care, but peers are an incredibly important part of that. And even if they're not there in the crisis moment, having them a part of the care team to say, hey, here's this person's contact information, use this as part of your support network next time you need somebody. We're working on that. So
I think Charlie first. Sarah Aker with our Medicaid team is going to be getting a call from me soon about the other piece, so I appreciate that little tidbit. And then I think, it's been something that we've been taking a look at the state level of how can we really utilize individuals with lived experience and be able to provide that connection to the services that we currently support. And we have had conversations around what could that look like in terms of specifically a crisis response kind of thing. Jason is still here. Hey, Jason. I know that we've talked about that in your area too, and that, that's something that you've got folks with lived experience, and they really could be a valuable piece to the crisis care kind of response efforts. And so that's certainly something that we're taking a look at.
I would say from the 988 perspective, I know there are 988 crisis centers that have a peer-based model, or they're exploring that. And so the Helpline Center, we don't have a peer-based model right now that's connected to 988. That's certainly something I think worth exploring, because I think they can offer an element of support to some of our callers. That is something that I think our counselors don't necessarily have or can offer. So I'm very open to exploring that and seeing how we can better serve the folks of South Dakota in crisis with that.
All right, we're out of time for this session, but if you have any other questions, you can talk to the panel individually. Thank you very much.